Hello, I'm Dr. Daniel Griffin.
And I'm Dixon DuPont.
And today we're going to be discussing family planning. Family planning is interesting because it's one of those areas where the role of the clinician, the role of the provider, may go outside of the bounds of what a lot of people consider medicine.
Okay.
It may go into the realm of, shall we say, healer, counselor, source of information. One of the things I will say is that there are very different thoughts, feelings, beliefs throughout the world with regard to family planning.
Also.
Some people believe that access to family planning is a fundamental right.
Yes.
Other people believe that family planning goes against a master plan and is something that certain religions are not comfortable with.
Yeah.
So today we're gonna talk about all those issues. So one of the first things, I'm going to tell a little bit of a story. When I was down practicing in the Dominican Republic, and I was asked to do a talk about family planning, so to speak. And this was a country where the Catholic Church is quite strong.
Yes, it is.
And certain interventions, certain family planning strategies were not permissible to be discussed.
That's right.
Communicated or taught in the schools. And one of the other groups that had been down there previously had violated that, and they were actually no longer welcome to go into the schools.
Wow.
So it's important, if you're thinking about discussing family planning, that you're aware of what are the social mores, what are the religious beliefs in the area, what are the judicial or legal constraints. And so one of the issues there was we had talked about a young man or a young woman might want to, and this was a school, a high school basically, so these were young men and women, and it was a discussion about one of the ways that they might prevent pregnancy, and we were allowed to say one may consider protection. You may use protection, but you couldn't get any more specific than that. You couldn't mention condoms or any other barrier type of family planning tool, technique, strategy.
Yeah.
I don't know. Have you had similar? You know, you travel quite a bit. So
Well, I didn't have to travel for this anecdote. I can tell you that for many, many years I used to give a lecture to the School of Public Health at Columbia on environmental issues related to ecological devastation of encroachment into natural systems. Sounds like a fancy word, but it means deforestation for farms, to raise more food, to feed more people. And prior to the first lecture in that series was given by our dean of the School of Public Health, who we've named an entire building after, Alan Rosenfield. And he was an enormous proponent of family planning strategies, ranging anywhere from free condom give-outs to public health education at every level, particularly in countries like Thailand and Cambodia, Laos. Southeast Asia was an area where he concentrated most of his activity.
Mm-hmm.
But he always used to come back to the fact that the Pope, the head of the Roman Catholic Church, was a huge influence in preventing people from adopting birth control measures, such as the pill or IUDs or condoms. The only thing they would approve of, according to his interpretation, was abstinence. So when I started my lecture, I would start by saying, excuse me, Dr. Rosenfield, can you please name the countries in Europe that have the lowest population growth? And he looked at me the first time I asked him that question with a puzzled look on his face. And he said, what are you driving at? I said, well, which countries in your view have the lowest growth in human population? And so he says, well, most of Europe is at a ZPG growth rate right now. He said, in fact, some are negative.
So ZP zero population growth?
Zero.
Zero population growth.
So I said, which ones do you think are negative population growth? And he says, well, because he was an expert on population. And he says, well, Italy is one of those countries, and France is another one. I said, stop right there. I said, what country, by the way, has more Catholics than any other country? And he says, well, Italy, per 1,000 people. I said, but apparently they're practicing some form of birth control because they have a negative population growth. In France, the other large Catholic country, also has a negative population growth. So I said, how do you account for that? And he smiled and he turned around and walked out of the room. He wouldn't answer the question. What he meant to say, I think, was that the Pope has an enormous influence on Latin America, where most of the out of control growth is perceived to occur. That may not be true, but that's the perception. So my take on family planning relates more to economic growth than it does to preventing the number of people. Because as we've learned, countries that have an increased rate of GDP have a lower birth rate as the result. And there's a point at where it crosses over, where you can exceed X numbers of dollars per family. And until that happens in all of the less developed countries, the growth rate will always be out of control because people are trying to replace children that don't grow up old enough to survive into adulthood. And that's, I think, the basis for the problem that we face. And it's an issue that doesn't relate necessarily to your religion, but rather to who will be left when I get old enough where I can't do anything else. I can't even walk, I can't move. I might be bedridden, I might not be able to work. Will I have any children left to carry on the family legacy for me? And I think that's a very common attitude. And I don't think it's fair to blame a religion on that. I think it's a practical aspect of poverty.
I think
that's my take on that.
No, I actually think that's really a good way to spin this, because we do a lot of times, we want to be righteous, we want to be indignant,
yes,
we want to say, if only so-and-so wasn't thwarting my attempts to make the world a wonderful place.
That doesn't look like that.
And I think it is more complicated than that. And in a lot of areas, there's a big economic impact on decisions, on opportunities, on population growth.
That's right.
And one of the things that, even though it's sort of broader than the topic of family planning, but reduction in child mortality usually translates into less pregnancies and less births. And that's an interesting issue. From a more, I'll say, individual focus, let's talk about how are the strategies that an individual might approach their interest in planning the family, in planning when they get pregnant. And we break it down into, I'm going to say, 4 different approaches. And as we talk about each, we'll discuss, where and when this might be considered acceptable or appropriate.
Sure.
And one of the first ones that is probably the broadest application is behavioral. And this is the decision of whether or not to have sexual relations. Because without sexual relations, it's very challenging to get pregnant.
Indeed.
And so a lot of contexts, the one thing they're willing to endorse is abstinence. They're willing to say that one of the options that is acceptable is abstinence. And you cringe. And what's the problem with recommending abstinence?
Because it says that the other methods that are more commonly used that work really well if you apply them are off limits because we don't approve of them. So we'll pick the only thing that doesn't work, and that's abstinence. Abstinence has never worked. If you go on a diet, you'll know what I mean. All you can think about is that nice big fat juicy steak that you said you're never going to eat again, and the next time you get a chance, a moment of weakness, you've had too many drinks perhaps, or you're out with friends and you don't want to seem like an outlier, you'll have that steak. And the urge to have sex is part of the human condition. And there's no way in any stretch of the imagination that you can will that urge to disappear just because you think that the other methods of birth control are religious tenets that you don't agree with. Abstinence has never worked. And it never will work.
So I guess I'll say, so abstinence is considered by many to be an approach with a low success rate.
I would say 0 success, but you say low, that's fine.
I think we should be. I think we should be fair.
Okay.
Some people have more self-control than others.
Some do.
Some people don't drink. Maybe that helps with self-control.
Maybe, perhaps.
Certain cultures, abstinence, particularly premarital abstinence, has some degree of success, but that's a point well taken. Abstinence is generally suggested to have a failure rate, a fairly high failure rate.
Very high.
The next one is we'll call fertility awareness, and this is calendar or symptom, sort of the rhythm approach. So this is where individuals may be sexually active, but they're timing or trying to time the sex relative to the cycle and relative to when a woman might get pregnant.
Right.
And there's a name. I grew up Catholic, and there's a name there was a name in the Catholic community for people that use the rhythm method, and we call them, I don't know if you're familiar with this term, but parents, because this also has a fairly high failure rate too.
Right.
But these can have some degree of success. Sometimes people use it the other way. They'll actually use the fertility awareness or calendar method to time when they do have the highest risk of conceiving.
Right.
Because they may have decided, okay, now would be a great time in my life to have a child, and so they'll have increased sexual activity right around that time. Another, and I'm going to actually put this in the same, we'll call it behavioral, is prolonged breastfeeding.
Right.
Not 100% effective,
It keeps the
but
hormone levels high.
by continuing the breastfeeding
That's right.
for, say, 2 or 3 years, this can actually, again, it's not 100%. Nothing's 100%, except maybe abstinence, which 100% doesn't always happen. But breastfeeding can actually help with spacing between children.
Sure.
And the spacing between children can lead to maybe better health for the mother and child in certain contexts,
Good.
Particularly when resources might be limited.
That's right. But the best control measure for preventing overpopulation in underdeveloped countries is economic development.
I think that's true. And I think that's always sort of the overarching thing for us to be thinking about when we're focused on individual recommendations, individual family planning. But if you can improve the economic context,
That's right.
if you can improve the economic opportunities,
Sure.
Next of our 4 categories, I'm going to talk about pharmacological.
Okay.
So our medicine, medication contraception, which had a huge social impact, I know, in the United States when it was first introduced.
Yes.
A lot of individuals considered this a freedom had come on.
Absolutely.
There was the ability to have sex with a significantly lower risk of pregnancy associated with that. So we'll talk a little. So in the oral contraception realm, we're going to say there are 3, I'll say, pill options. So we have combined, which are estrogen, progesterone combined.
Right.
We have a progestin only, and also we have emergency,
Yep.
where someone might have a sexual experience, and then in some situations there can be a morning after pill, as it's called.
Sure.
Injectables are another approach, and there's a couple different preparations. One that's quite common through a lot of areas of the world is the medroxyprogesterone acetate. And this is 150 milligrams, it's a 1 milliliter injection, and it's done once intramuscular every 3 months.
Great.
One of the things I sort of say a pearl again, a thing to think about, is when you do this, often the women don't necessarily want their husband to know, and in certain cultures and contexts that might be appropriate for that separation. So a lot of times they'll ask for this to be done in private. They won't want a Band-Aid, because now everyone, why do you have a Band-Aid on your shoulder?
Sure.
And they'll also, even though the shirt might be covering the shoulder, it may not go down very far. So you'll look at doing these injections in a private place, so to speak. Private setting, in an area where the injection is then going to be covered with clothing. But again, this is a commitment, because this is going to be in every 3 months for the injectable.
Exactly.
Patches are another option, a little more challenging in a tropical, humid, hot environment. And vaginal rings, medicated vaginal rings. Mechanical, which I think you alluded to a little bit before, we'll say. So we have our behavioral, our pharmacological, and we'll say mechanical. This might be condoms.
Sure.
Famous restaurant in Bangkok, condoms and cabbages.
That's right.
Where condoms not only play a role in family planning, but they may play a role in disease transmission.
Exactly.
So interrupting the transmission of sexually transmitted
Sure.
infections.
Absolutely.
Diaphragms, cervical caps, and vaginal rings. Again, it's got the medication. You're kind of having both effects here.
Yep.
And surgical.
Well, IUDs fall into that.
So you're going to put that in mechanical? No, it is. No, I think it's good.
Probably.
Yeah, so the IUDs will put into mechanical, and the way they're working is actually by irritating the uterine lining
Exactly.
and preventing implantation. That, you can imagine certain people with religious beliefs can be quite an issue because it's still allowing fertilization to occur.
And then the ovum gets destroyed.
And then, exactly. So, and then surgical. And the surgical is permanent, more permanent.
Sure.
And this would be for the male would be a vasectomy, and for the female might be, well, female sterilization, the tying of the tube, surgical ligation.
Yeah, it's a complicated story, and it's still being debated, and we've got, fairly well-developed countries like the United States is still arguing as to whether or not abortion is a method for birth control. I wouldn't recommend that as a birth control measure, but I would not prevent a woman from determining what happens to her own future by simply stating that the law says that you're not allowed to have an abortion up to a certain number of months after impregnation occurs. So it's political, sociological, and then lastly biological.
Yeah.
And it's a very difficult issue.
Well, I hope as you've also gotten from our discussion today is people have a lot of strong feelings on both sides.
Oh, no question about it.
And so as a provider, it's a challenge.
Yep.
Because you're really not there, I should say, advancing your own agenda, but you're there as an advocate for your patient. You're there to listen to their beliefs and to do everything you can to help them advance their goals.
Yes.
So complicated area of medicine where it really stretches our cultural competency.
That's right.
Our sensitivity, and our ability to step outside ourselves and step into the shoes of our patients.
Exactly.
All right, well, thank you for joining us today.
Yep, we'll see you again.